Hello everyone, thank you for attending this lecture. First of all, I have low conflict of interest in relation to this presentation. So before we talk about the blocks and also the nerve injury, as an introduction, major shoulder surgery can absolutely lead to quite a lot of post-operative pain, which is difficult to manage. Whereas if you even do some intermediate shoulder surgery, for example, arthroscopic surgery, um, quite a few patients would still require regional block for post-operative rehabilitation. For example, the continuous passive motion, so that they can improve their range of movement. So in the past 1 or 2 decades, interscalene brachial plexus block was regarded as the gold standard in shoulder surgery. However, if the patient has some severe pulmonary pathology, this interscalene brachial plexus block would possibly be contraindicated because the risk of blocking the phrenic nerve or even injuring the phrenic nerve. And there is also two other nerves. One is dorsoscapular nerve, another one is a long thoracic nerve. They are relatively overlooked by anesthetists, but they can be inadvertently injured by the classical lateral to medial approach. So I will further elaborate later. So first of all, I want to talk about the phrenic nerve injury. So how common is this problem? Actually, very common. If you inject 20 ml of local anesthetic, the incidence is almost 100%. And if you can reduce our local anesthetic down to 5 ml, you can still have half of the cases get involved the phrenic nerve. And if you can identify the anatomy well and you know the nerve root well, you can count it well, you can do a C7 nerve root injection by 10 ml of local anesthetic. And in this approach, almost 87% of cases will be spared, but the block is still a successful. People also look into whether the injection of the local anesthetic anterior to the interscalene groove or posterior interscalene groove, whether there is any difference between these two approaches. And the volume they injected is 5 ml high concentration 1% ropivacaine to each of the C5, C6, and C7. They found that no difference because when you look at the data below, no matter anterior posterior approach, the respiratory spirometry is also significantly affected after the block. And the proposed mechanisms of this phrenic nerve block, there will be two. One is the rostral spread of local anesthetic toward the C3 and C5 nerve roots. Another one is the anterior local anesthetic migration from the interscalene groove toward the phrenic nerve. And that's why since 2010, the American Society of Regional Anesthesia and Pain Medicine recommended against the use of interscalene block in patients who would fail to tolerate a 30% reduction in pulmonary function after the interscalene block. And in fact, not only block, there are case reports suggesting a risk of injury of the phrenic nerve after the interscalene block, especially use a medial to lateral approach because the needle may directly block the phrenic nerve. I will further elaborate the anatomy later so that you can understand why the medial to lateral approach is so dangerous. So dorsoscapular nerve, as I said, is relatively overlooked. but you can still find some literature about the case report of dorsoscapular nerve injury after the interscalene block. And this is a very nice illustration of the dorsoscapular nerve or non-thoracic nerve encountered by your needle during the interscalene brachial plexus block. And you can see basically more than 60% of cases the needle will encounter the dorsoscapular nerve, whereas the it's less common to encounter the non-thoracic nerve, but still 20% of the cases. For those non-pain physician, they may not understand or they may not know the clinical presentation of the dorsoscapular nerve injury. Now, there will be two types. One is a less serious one, which is a neuralgia, and the other one is more serious, is a palsy. For those patient presenting with dorsoscapular neuralgia, the patient will develop some etching pain over the interscapular area, laterally, and very uncomfortable. And these etching pain would correlate to those rhomboidal or minor and major. Okay, for those serious one, you can see a clinical picture called ring scapula as shown in the slide. So here comes to some anatomy before we talk about the regional block. So you can see the dorsoscapular nerve emerges from C5, whereas the long thoracic nerve also emerges from C5, but also with some contribution from C7 and C6 as well. So this is the graphical illustration over there of the long thoracic nerve and also dorsoscapular nerve. And basically, one important thing for the dorsoscapular nerve is they will pierce classically and commonly pierces the middle scalene muscle and then continue deep to the levator scapulae and then corner to the rhomboidals at the back of your body. However, it's not so simple. So in Japanese population, there's a group of Japanese doctor study about the anatomical variants of the dorsoscapular nerve. They found that apart from the piercing type, which is quite common, there's also another type called anterior type. So what you mean by anterior type is not piercing the middle scalene muscle, but just run superficial to the muscle before it cornering to the back of the body. So here are some sonographic images to show the how variable of the dorsoscapular nerve in the middle scalene muscle and as well as the long thoracic nerve. So this is the dorsoscapular nerve, this is the long thoracic nerve, and this is the interscalene trunk, interscalene group, sorry. And this is another one, is a middle scalene muscle, and this is dorsoscapular nerve. This is a dorsoscapular quite close to the superficial part of the middle scalene, but I would still regard it as a piercing type. There's a long thoracic nerve. So this is another one, and dorsoscapular nerve. Dorsoscapular nerve. So you can see how difficult you can identify because it's so tiny, and some anesthetists, especially for those inexperienced one, they would just regard it as artifact or the muscle fibers, the fibrillary pattern of the fibers. How about phrenic nerve? Phrenic nerve usually descends obliquely with the internal jugular vein across the anterior scalene and dip to the prevertebral layer of the deep cervical fascia and transverse cervical and suprascapular arteries. So again, it's a tiny nerve above the anterior scalene muscle usually, but it can be also located right above the interscalene groove. So this is a phrenic nerve. This is the phrenic nerve, okay? So this is also a phrenic nerve right above the interscalene groove, phrenic nerve. So it's quite common. So how can we minimize the risk of blocking or even injuring these three nerves? So let's go through some traditional ways if we want to stick to interscalene brachial plexus block. For phrenic nerve, people used to suggest to use finger to prevent the cephalic spread of outlook anesthetic, but it has been proven to be not useful. Some more constructive suggestions include decrease the local anesthetic volume down to 5 ml, okay, and also the use of diluted local anesthetic by the use of 0.1% ropivacaine or 0.125% ropivacaine, and people also try to in the past also try to use the extravasal injection compared with the subvasal injection. However, there were still around 20% of the cases block the phrenic nerve. And lastly, some people would do the supraclavicular brachial plexus block, but the incidence can still up to 34%. When we look at the dorsoscapular nerve and long thoracic nerve, you basically it's very difficult to identify first of all, and therefore people used to suggest to you the use of nerve stimulation during your leader advancement. Is a valid way, but the problem is it may lead to some twitching of the muscle while your leader advance and may lead to patient discomfort and also complicate your um, procedure because the patient leg keep twitching. Okay, and therefore people think of some dorsal phrenic nerve and dorsoscapular nerve sparing blocks. Before I introduce some combinations or some options to you, we have to there are two considerations that we have to think of. One is the extent of the shoulder surgery. It can be arthroscopic, it can be open. For arthroscopic surgery, you have to know where the parts will be put there and how many parts there. And for open surgery, you have to understand which approach of the open surgery the surgeon would do. Is it a transpectoral or the transdeltoid? So they are totally different. And also we have to understand the shoulder joint innervations. So this is a slide to highlight the shoulder joint innervations. I divide them into joints, soft tissues, and skin. And you can see the major nerves involved in most structures are the suprascapular nerve, axillary nerve, lateral pectoral nerve, and also for the skin is a supraclavicular nerve, which is from superficial cervical plexus, but not the brachial plexus. So if you can block all these nerves, okay, basically you can block the whole shoulder. But of course, some nerves are quite difficult to block, so I'm not going to talk about them. So here are the options I would like to introduce today. They are suprascapular nerve block, suprascapular nerve plus axillary nerve block plus or minus lateral pectoral nerve block, the superior trunk block plus or minus supraclavicular nerve block, and the infraclavicular brachial plexus block, especially costoclavicular approach, plus the suprascapular nerve block. And lastly, the upper thoracic or even cervical block. So first of all, I want to discuss about the suprascapular nerve plus the axillary nerve blocks. Now, if you still remember the anatomy slide I just showed you, of course, if you just block these two nerves, what it can offer is just partial analgesia. And and although it has been shown to be better than intraarticular or subacromial local anesthetic injections, in fact, is absolutely inadequate for major non-arthroscopic surgery, especially if you just inject the suprascapular nerve. So the conclusion, according to evidence, is only adequate for arthroscopic surgery. So, so how do we do the suprascapular block? So this is the classical approach. We usually turn the patient lateral or ask the patient to sit up, um, and we and then we use the linear scan to put between the spine or scapula and also the clavicle. And after tilting the probe, you will identify a trough on the bony surface, which would correspond to the suprascapular groove or suprascapular lodge. Okay, although they are different, actually, to most of the general anesthetists, they are actually similar. And I would not further delineate the difference between the groove and also the lodge. What you need is to identify there's a tiny line above this suprascapular groove or lodge, and this is called transverse scapular ligament. And underneath it, you will appreciate some pulsation, which is the suprascapular artery, and the nerve is usually lie adjacent to it. So what you need is to put your needle lateral to medial or medial to lateral, and then pass through the transverse scapular ligament and inject around 5 mil of local 5 mil of local anesthetic, and you can faithfully block the suprascapular nerve. If you want to use a motor, if you want to use a nerve stimulation, what you will see is the twitching of the supraspinatus muscle just above the transverse scapular ligament. However, the disadvantage of the classical approach is you have to turn the patient or sit up the patient, um, which is not so convenient because you have to block, especially you want to block especially if the patient is anesthetized, or you want to block the brachial plexus as well. So here comes to a new approach of suprascapular nerve, which is called anterior or subomohyoid approach. So you can see the suprascapular nerve after branching out from the brachial plexus. It will follow um, the path parallel to the omohyoid muscle before it curve to the suprascapular groove. So this is the suprascapular nerve underneath the omohyoid muscle, and you can see the interesting thing is it So this is a C5 and C6. Sometimes they're too low because they will branch a little bit, but so don't mistake it as a C7. And then these C5 and C6 form this superior trunk. And don't forget that this dorsoscapular nerve also just branch out from the C5, okay? So there is a middle scalene, dorsoscapular nerve, superior trunk, anterior scalene. And then you use a needle lateral to medial. And then hydrodissect the superior trunk. And for this case, we just inject the local anesthetic above the superior trunk, and then we withdraw the needle a little bit, and then inject local anesthetic to block the supraclavicular nerve selectively, just like this. Okay. So now it comes to the infraclavicular block plus the suprascapular block. So there's quite a few of a study talking about the use of infraclavicular block. In the past, we all think that is inadequate to block the shoulder, but then if you add the suprascapular block, it seems it's a reasonable combination. So for this study, they compare the combo between costocapicular blocks with the interscalene nerve block. They found that in terms of the post-op analgesia, they are equivalent, okay? But then the phrenic nerve block is basically zero for the costocavicular costocavicular infraclavicular brachial plexus block, whereas the interscalene block result in 100% of hemidiaphragmatic paralysis in this study. But bear in mind, the last study is just a arthroscopic surgery, but not a open surgery. And then there's another combination is another study, actually case report from Egypt, is a anterior approach of subomohyoid approach of suprascapular block plus the infraclavicular classical brachial plexus block. What they do is they use a single puncture technique. After the interscalene brachial plexus block, withdraw the needle, tilt the block a little bit, and then they block the suprascapular nerve block just below the omohyoid muscle. And then for the skin, because they didn't block the supraclavicular nerve block, it's done by the surgeon by local anesthetic infiltration. And this combination could result in a complete anesthesia without any need of converting to general anesthesia. There's another case report to use this approach for total shoulder replacement. Okay, but this is a general anesthesia plus the block. They use a classical infraclavicular brachial plexus block plus the classical approach of suprascapular block, and then the skin is also done by local anesthetic infiltration by surgeon. And with such a low dose of parenteral analgesic of fentanyl and ketamine, the patient could enjoy a complete pain relief after the anesthesia. So lastly, the last block I would like to introduce is the upper thoracic or the cervical erector spinae block. So for those regional block lover, you must know that ESP block is so popular in the recent years. There are a lot of study for different surgeries. Okay, so certainly shoulder surgery won't be missed, and there are some case report to use of erector spinae plane block for shoulder surgery. Some people will use say upper thoracic ESP block at T23. Some people will even do it at the C7 level, okay, or even put in a catheter at that level. For those who are not familiar with the anatomy, they would query how to put a erector spinae plane block at the C7 level. Now, by the analogy of the anatomy, they will put the local anesthetic or the catheter at the posterior tubercle of C7, okay? Um, and then they put in the catheter, local anesthetic there, and then C7 nerve root, vertebral artery. Personally, I haven't tried any ESP pain, USP block in shoulder surgery, because I believe direct nerve block to those superior trunk or peripheral nerve seems to be more reliable. But then another thing is if you want to block the C7, you have to learn the anatomy very well, because the interesting thing or the special thing of the C7 foramen is they only have a posterior tubercle but low anterior tubercle, and therefore the vertebral artery is exposed but not protected. So if your needling is not good, there is a potential risk of puncturing the vertebral artery or even injecting the local anesthetic into the vertebral artery or injuring the nerve root. And that's why I would not recommend this to those inexperienced anesthetists to do this. Next, if even you do a T23 level, but just a low infusion rate of local anesthetic, this can lead to a very good spread of local anesthetic from C3 to T3, okay? And the patient can also have a reduction in pinprick sensation, okay? In fact, there are some ongoing study to look into the difference or the comparison between the erector spinae block and shoulder periarticular injection or the interscalene nerve block. So let's see whether the ESP block will turn out to be another proven alternative to interscalene block. So my conclusion today would be when you inject local anesthetic, perform your classical interscalene block, you have to be very careful about the phrenic nerve block injury plus the dorsoscapular nerve plus or minus long thoracic nerve injury. And then I think it's time to have a paradigm shift to the newer block combinations, and because they seems to be safer and also confer equivalent analgesic benefit. So the statement of gold standard of interscalene block in shoulder surgery may be out of favor now. And when you consider your option for the shoulders regional block for shoulder surgery, please remember to talk to your surgeon about the approach or the exact incision, because this is very important for your planning. And lastly, understand your anatomy and practice, and inject with your love and passion for your patients. Okay, thank you.